Good evening. Welcome to our GP education event tonight. I'm Lena Nido. I'm the GP liaison officer at the Ioneer Hospital. My usual working day there is Thursdays, and I can be contacted by emailing gpliaison@ioneer.org.au. It's best to use that email address rather than my personal address, as other team members check that on days that I'm not there and also when I'm on leave. I'd like to acknowledge the people of the Kulin Nation, who are the traditional custodians of this land that we meet on today. I'd also like to pay my respects to elders past, present and emerging, and to any Aboriginal people joining us for the webinar today. I'd especially like to acknowledge our speaker, Dr. Lana Del Porto, who's generously donated her time and expertise to provide this presentation. I'd also like to thank the North West Melbourne Primary Healthcare Network for partnering with us to provide this GP education event. We're also very grateful to the Collier Fund, who have generously donated a grant to assist us to fund our GP education program. Now, with regards to questions, so all of the audience members are muted. If you'd like to ask questions of myself or our speaker, Lana, then please type them in the question box. So if you look at your GoToWebinar control panel, which is on the right of my screen, but might be somewhere else on your screen, about 1, 2, 3, 4 or 5 or 6 arrows down, it says questions. If you click on the triangle, open that up, and you can type questions in there to me. I'll be moderating those questions as we go along and asking them at the appropriate time. So if it doesn't get asked straight away, don't worry, I may be coming back to it at the end. If you have any technical issues, then please type them in the chat section. So that's the bottom arrow section. And Jen from the Northwest Melbourne PHN will be supporting us and monitoring those. We are recording this event, and also it'll be made. I'll email when it's available online from the hospital website. Also, feel free to have a look at our GP education page on the hospital website, because there's many other previous recorded events there. Evaluation forms or surveys will be emailed to you at the close of the webinar by Jen from the Northwest Melbourne PHN. Please complete them straight away. We do value and use this feedback to plan our future events. It's also necessary for allocating RAC, GP, CME or QI and CPD points. Okay, so I'm just going to quickly run you through the Ioneer Hospital website. There are COVID hospital updates on there and other bits and pieces of information, and that's ioneer.org.au. Referring to the Ioneer, if you click on health professionals for GPs, there's all the information about referring. We have our referral guidelines. And I just want to mention the Department of Health has introduced statewide referral criteria. They've been slowly introducing those over the last couple of years for various specialties, and those for ophthalmology have just been introduced on the 1st of May. The statewide referral criteria provide clear guidance to referring clinicians about which patients will be seen in specialist clinics and what investigations are required to support safe and appropriate triage. Statewide referral criteria are shared by all Victorian hospitals, making referral clearer and more equitable. The referral criteria are being developed by the Department of Health and Human Services with consultation, well, they have been developed through clinical review panels, and panel membership consisted of heads of units or specialists from across Victoria, health service, nursing, allied health clinicians, GPs and GP liaison officers. So from the 1st of May, selected conditions for ophthalmology will be assessed against the statewide referral criteria. This follows on from the launch of ENT, vascular and neurology that were the first ones launched on the 1st of November 2019. If you don't follow the statewide referral criteria, a referral that does not meet the criteria, either because it doesn't meet the threshold or there's essential information missing, will actually be returned to the referrer. You should get a letter back from the health service clearly stating why the referral's been declined. Health pathways are there to actually support you with this process. So for all of the statewide referral criteria that have been introduced, there are corresponding health pathways to help you manage the condition in general practice and know how to investigate, work them up, and they very clearly state when referral thresholds have been met, when you can refer. There's also pathways guiding you where you can refer and what information you need to include. So the eye conditions that have statewide referral criteria are listed there. Many of these will actually be touched on in our presentation today as causes of visual loss throughout the lifespan. If you look at vision loss on health pathways, you can see those conditions will come up, and then you click on various ones to follow the pathways. They're all the conditions that are covered in health pathways, but I won't show you each of the pathways. So how can you get access to health pathways? If you don't already, you'll need a login to access health pathways. You contact your local PHN. So if you are in the Northwest Melbourne PHN area, then you can contact them to get your login and password. But if you're outside of that area, almost all areas in Victoria have health pathways, and you just need to contact your local PHN. Alternatively, you can look at the statewide referral criteria on the DHHS website, but it doesn't give you the pathways of how to manage. So there are learning objectives. I won't go through them. I'd just like to introduce Lana Del Porto, who's an ophthalmologist. Just have to move my screen. She completed her medical degree at the University of Sydney, graduating with honours. Her ophthalmic training was at the Royal Victorian Eye Hospital and subsequently at the prestigious Moorfields Eye Hospital in London. She's a fellow of the Royal Australian and New Zealand College of Ophthalmologists. She completed research in thyroid eye disease, has multiple publications in the medical literature, and has been an invited speaker at international conferences. She's dedicated to providing the very best of care for her patients. She has extensive experience in the treatment of cataract and age-related macular degeneration, strabismus or squint, paediatric ophthalmology, thyroid eye disease, and neuro-ophthalmology. Dr. Del Porto has 3 private practices in Glen Iris, Springvale, and Cheltenham. She's a consultant at the Royal Victorian Eye Hospital, where she teaches cataract and squint surgery. So I will ask Jen to switch from sharing my screen to Lana's. And I'll be here in the background, but I will turn my video off.
Okay, thanks very much for inviting me to speak today, Lena. So I wanted to cover the common causes of vision loss throughout the lifespan. I'm trying to focus on conditions that may actually present to you guys as GPs. The learning objectives were to outline a GP assessment and diagnosis of the common causes of vision loss. And I'm focusing on each different age group as we go throughout the lifespan to try to focus on the red flags for sight or life-threatening disease, describe the GP assessment of amblyopia and list its common causes, list the common causes of vision loss in the Middle Ages, including age-related, sorry, I can't see my own screen. There's got to be a way to close this. No. To detail the assessment of the elderly and common causes of vision loss that occur in the elderly, such as age-related macular degeneration and cataract. So the outline for today, I wanted to cover 9 clinical cases. Each are going to demonstrate some of the most common causes of vision loss in each age group, each with clinical pearls about history and examination and diagnosis. Obviously, I can't cover every diagnosis that exists, but I'm trying to focus on the most relevant things that may present to you guys as GPs. So the case 1 is an infant, so it's a 6-month-old girl. Mum is concerned about the presence of a white pupil. Mum thinks that her baby cannot see well out of the affected eye. So something like this may come to you via a maternal child health nurse who might notice, poor red reflex or a white red reflex, and they may ask the GP to refer to an ophthalmologist that way. So how do we assess vision in babies and children? So with babies, it's simply, do they fixate on an object of interest and follow it? So a pen torch would work fine, or a toy. Make sure it's a toy that doesn't make noise, because then they'll follow the noise. Then also, is there objection to cover of one eye versus the other? Children may know the letters on your Snellen chart if they're a little bit older. Otherwise, there's picture matching charts, such as K pictures or Leah symbols. And there's an example of Leah symbols over here. So most kids will be able to say, that's a square, that's an apple, that's a house, that's a circle. And you can download these from the internet the same way you do with a Snellen chart and put it on the wall in your rooms. So what are the causes of white pupil? Well, actually, there's about 15 different causes, but some of the most important ones are cataract, retinoblastoma, which is, of course, a retinal disease in childhood, where you get basically the infantile retinal cells become a tumour. Koch's disease, which is a neovascular malformation of the retina that you see in young boys. Retinopathy of prematurity is a picture of that here on the side down the bottom. Is another cause, and persistent fetal vasculature. So leukocoria in an infant is always requiring urgent assessment by an ophthalmologist. Next case is a child. So it's a 4-year-old boy. Mum notices that one eye is turning in. So which eye is turning in, and how can you tell? So the simple answer there is, what you want to do is learn to assess the light reflex. It's extremely useful for assessing whether a child has a true squint or a pseudo squint. So you direct your pen torch at the child's eyes, and you note the position of the light reflex in each pupil. So a child with strabismus or squint will have a decentered light reflex. So the second picture here shows an abnormal light reflex, indicating that there is abnormal ocular alignment. So in this case, there's a left exotropia, because you can see that the light reflex has decentered inwards. So a child that has an obvious squint will need an urgent referral to an ophthalmologist. So what is the most common cause of vision loss in childhood in Australia? The answer is amblyopia, or lazy eye. Amblyopia is the most common cause of reduced vision in children in developed countries, with an incidence of approximately 3 to 6%. Now, it's defined as a reduction in the visual acuity in one or both eyes that cannot be attributed to an ocular disease or abnormality. And it occurs due to suppression of the visual cortex in order to overcome blurred vision in one eye or diplopia. So it often develops secondary to other eye conditions, such as strabismus, refractive error, or even cataract. But why is amblyopia important? Well, firstly, the treatment of amblyopia is time critical. The child's brain pathways are set by the age of 6. Therefore, if the diagnosis is made too late, the vision will be lost forever. Secondly, amblyopia is very easily treated with patching of the good eye in order to encourage the child to use the weaker eye. And treatment of the underlying cause is often important as well, such as glasses for refractive error, squint surgery, or cataract removal. And here's that child again. What you can see is his right esotropia is completely resolved by wearing spectacles. So what is the most common cause of amblyopia? Well, refractive error, something like a +5 in one eye and a +2 in the other eye, is the most common. A child will suppress the images coming from the more plus eye. So they'll suppress the images coming from the +5 eye. Strabismus is the next most common, and that would be usually esotropia is more amblyogenic than exotropia. So an eye that turns in often causes more vision loss than an eye that turns out. Or there's a combination of refractive error and strabismus. And then, of course, there's other ocular pathologies. So if a child has cataract, they will get secondary amblyopia in addition to the cataract, causing further sight loss. And of course, something like congenital ptosis, a child will get occlusion amblyopia. Next case, we're moving on in life. So it's an adult in her 20s. Most of these cases are real people that I have met. I've just obviously taken their names out. It's a 25-year-old woman, type 1 diabetic, and she has not been taking her insulin properly. She has been doing this in an effort to try to lose weight. She does take her insulin, just not, the way she's supposed to. She's never had an eye check, and now she reports sudden vision loss in her left eye. So her vision is 6.6 in the right eye, so perfect vision, and the left eye vision is 6.60, so 10%. Her blood sugar when she's with you is 24. So this gives me a nice segue into talking about vision testing. So vision testing should be done at 6 meters, and we test each eye separately, and you ask the patient to wear their distance spectacles. Now, if your room is a bit small, like mine, you can use a 3-meter chart. These can also be just downloaded and printed from the internet. Vision is written as a fraction with the distance on top. So 6.6 is 100% and 6.60 is 10%. Now, if the vision is worse than 6.60, this is how you grade it. So the next is count fingers, hand movements is next, perception of light, and then no perception of light. So diabetic eye disease comes in 3 main forms. The first is diabetic retinopathy. What occurs here pathophysiologically is that you see elevated blood sugar levels that cause damage to the tiny blood vessels of the retina in the same way it does in the kidney. Now this causes retinal ischemia that leads to growth of abnormal new blood vessels. And if this neovascularization is left untreated, then bleeding can occur and fibrous tissue can grow, which causes blindness. The next thing is diabetic macular edema. So the tiny blood vessels at the macula are very susceptible to elevated blood sugar levels and can leak fluid, causing macular swelling. And the final thing is cataract. So diabetes can lead to an earlier onset of cataracts and faster progression of cataracts than you would otherwise see. So which of these do we think that our patient has? Well, this is what our eyes look like. So as you can see, the right eye, there is extensive neovascularization of the disc that extends outwards from the optic nerve. And this is proliferative diabetic retinopathy. Now, this patient requires urgent laser to her peripheral retina, and we call that pan-retinal photocoagulation. And this controls the neovascularization. The left eye, on the other hand, has had an extensive intravitreal hemorrhage. So this eye would need a vitrectomy. So a retinal surgeon would have to come in and clean this up, and probably pan-retinal photocoagulation of the retina at the time of that operation. So next case is an adult. Now we're moving to our 30s and 40s. It's a 36-year-old man who reports sudden vision loss in his left eye. So now we're going to start talking about history. What do you want to ask on history? So taking a history of vision loss. Firstly, the time course is very important. So if a patient says that they lost vision within a few seconds, you need to think vascular. So think of an ischemic cause, such as a retinal artery occlusion, or an acute hemorrhage, like a submacular bleed from macular degeneration, or a vitreous hemorrhage, like in this patient's case. If the time course is more like minutes to hours, we think of something like a retinal detachment or acute angle closure. If the time course is days, it's usually inflammation that is the problem. So this is things like optic neuritis or uveitis. If we're looking at weeks to months, we're thinking about a tumour. So this would be something like a compressive optic neuropathy. And finally, if it's years and years, it's often cataract. The next thing is to ask about bilateral versus unilateral vision loss. And I've tried to keep this talk mainly about unilateral vision loss for simplicity. So if you've got a patient with unilateral vision loss, then it always indicates a lesion that is anterior to the chiasm, so optic nerve or the eye itself. If it's bilateral simultaneous vision loss, it's almost never from the eye itself. It must be from the brain. So this is when we're thinking about cortical vision loss. So a massive stroke affecting both visual cortices, migraine, of course, or even postural hypotension is probably the most common cause for bilateral simultaneous vision loss that I would see in my clinic. But of course, that is temporary vision loss. It comes back if it's postural hypotension. And then finally, sequential vision loss. So one eye and then the other. Unfortunately, this can really be anywhere. It could be the retina of one eye, the optic nerve of the other. It could be a chiasmal problem, or it could be anywhere, retrochiasmal. So optic tract, LGN, optic radiations, primary visual cortex. Now, final thing with the history, don't forget to ask about other symptoms. So I didn't want to focus too much on pain because, this is supposed to be about, vision loss, not pain. But obviously you do want to ask about pain associated with vision loss, just in general. So if the pain is in the eye itself, you think about angle closure. If the pain is periorbital, in that it's, say, worse on eye movement, we think about optic neuritis or thyroid eye disease. If there is associated headache, then we think about giant cell arteritis, migraine with aura, intracranial mass, or another cause of elevated intracranial pressure, such as idiopathic intracranial hypertension. Then, of course, we want to ask about other neurological symptoms, such as diplopia or double vision. Then you would think of perhaps an orbital apex lesion, because orbital apex carries cranial nerves that control eye movement as well as the optic nerve. If they report facial numbness, you need to think of cranial nerve 5 problems, and where the cranial nerve 5 would be compressed along with optic nerve problems, and that would be the cavernous sinus. And then if there's ataxia, hemiparesis, hemisensory loss, obviously we're thinking brainstem or cortical lesions due to stroke or demyelination. So back to case 4. On further questioning, this 36-year-old man reports flashing lights and a shower of floaters, followed by a curtain that came up over his vision. And he is myopic, -11 in both eyes. His vision, when you test him in your rooms, is 6/6 for the right and hand movements for the left eye. And this is what it looks like. So the diagnosis is that he's had a left superior retinal detachment, and in fact peripherally in that same eye you can see some retinal holes. And what is the treatment? Well, for the holes you would do either laser, you do laser, but in this case this patient needs a vitrectomy for his left retinal detachment. Common causes of unilateral vision loss in young adults. So look, the most common cause is actually refractive error. So, you know, in this case, the vision will actually improve with a pinhole. It's very unlikely that patients with refractive error are going to present to you. Other common causes in the, you know, younger age groups are optic neuritis. Now, these ones will have an RAPD and pain on eye movement. I'm going to talk about RAPD in a few minutes. Other common causes are retinal detachment. These are usually high myopes, like our patient here was -11, or often have a history of ocular trauma. Uveitis. In these patients, the eye will be red and very, very light sensitive, very photophobia. Other causes are ocular infection, such as microbial keratitis in contact lens wearers, or HSV keratitis in patients with a history of cold sores. And then, of course, diabetic retinopathy or ocular trauma. So we're moving on to case 5. This is an adult in his 50s. So it's a 51-year-old man, and he has a history of sleep apnea. Now, he went to bed with normal vision and woke up with the lower half of the vision missing from his right eye. He tells you, well, you know that he takes Viagra. Vision is 6/36 in his right eye, and in the left eye it's 6/6. There is an RAPD. So my next question is, what is an RAPD and how do you test for one? So an RAPD is a relative afferent pupillary defect. Now, the way to assess it is, firstly, you dim the room lights and you ask the patient to look in the distance, because if the patient is looking for near, they'll get a convergence response and they'll have small pupils. So you want to look in the distance in the dark so the pupils are pretty big. Now, you use a bright pen torch. You test each pupil separately for a direct response. Okay, so you want to know that you've got a direct response before we start swinging the torch back and forth. Then you do your swinging torch test. So what you will see is a paradoxical pupil dilation of the affected eye when the torch is shone on it. And this is because it reacts poorly relative to the normal pupil. So I've just got a picture here. So both pupils here, we're looking at the green eye at the top if you can't see my pointer. Both pupils are about the same size in the dark, looking in the distance. You shine it on the right eye and you get an equal response. You shine it on the left eye, you get an equal response. Now, with an RAPD, you shine it on the right eye and both pupils constrict nicely. You shine it on the left eye, and what you'll see is a paradoxical dilation of that left pupil because it doesn't respond as briskly or as dramatically as the normal pupil. So this video is really useful just to demonstrate. It doesn't really matter if you can't hear it.
In this patient, you will see that the right pupil consistently dilates as the light is swung toward it. This dilation is called a relative afferent pupillary defect. It usually signifies that an optic nerve lesion is present on the side of the dilating pupil.
Okay, so that's probably enough of that. So why is testing an RAPD important? So the presence of an RAPD indicates sight loss due to optic nerve or severe retinal damage. Therefore, when it is present, the patient requires urgent referral to an ophthalmologist, usually that same day. The other option is to send them to the eye and ear emergency department. The RAPD is really the only true objective measure of visual function that we as doctors can perform, because every other vision test that exists is subjective. So that is why it's important. So back to case 5. So what you can see here is that his right optic nerve, the one with vision loss, has swelling on its superior half and a disc hemorrhage related to that. Meanwhile, the left optic nerve looks normal, although it's a bit small and a bit of a small cup. The visual fields also indicate that there's been a vascular problem because there is inferior field loss, which matches the disc appearance. So whatever happens to the superior disc will be seen on the inferior visual field of that eye, because everything's flipped in the retina and optic nerve. So this is a non-arteritic ischemic optic neuropathy, or an NAION. So what happens here is there is an occlusion of one of the short posterior ciliary arteries which supply the optic nerve head, and that's these ones here, and they supply the optic nerve half and half. So superior half is one of the short posterior cilaries, and the inferior half is the other, which is why you get, one half of the optic nerve will swell and one half of the field will be lost. Now, the risk factors for this are sleep apnea, nocturnal hypotension, so going to bed very dehydrated or taking antihypertensives at night rather than in the morning, a small optic cup and small optic nerve, smoking, and Viagra. It's related to poor oxygenation of the disc at night due to hypovolemia or hypocarbia. Although the Viagra, I'm not entirely sure of the mechanism. So 10% have occurrence in the fellow eye, and we must rule out GCA in these patients, especially if they're over 50. So what is GCA? So giant cell arteritis is an arteritis that has a predilection for the large and medium-sized arteries. And these all pretty much are in the face. So these are the superficial temporal, the posterior ciliary, and the proximal vertebrals, which is why they often have, I always do this, so they often have jaw claudication, they have vision loss, they have scalp tenderness, and temporal headaches. And those are the things that you want to ask about. In addition to that, you want to ask about joint pain, weight loss, fever, night sweats, and malaise. And don't even bother if the patient's less than 50. They're not going to have temporal arteritis if they're less than 50. So investigations include ESR, CRP, and platelet count. These are all typically elevated, and the diagnosis is made via a temporal artery biopsy, which we do at the eye and ear. The prognosis is generally quite poor. There's usually severe vision loss, and then about a third can develop involvement of the fellow eye within a week. So there can be multiple pathways for vision loss with this disease. The first being a central retinal artery occlusion. You can also have a cilio-retinal artery occlusion. There can be amaurosis fugax, diplopia, stroke, or even I've seen a patient with fulminant scalp necrosis. Treatment is with intravenous steroids for 3 days. We do that at the eye and ear, and then oral steroids for approximately a month. So what are the most common causes of vision loss in the middle years in the developed world? Well, diabetes, diabetic macular edema, and diabetic retinopathy. And then there's also vein occlusions. So branch retinal vein occlusions, central retinal vein occlusions. These can also lead to macular edema or just vision loss because of the vein occlusion, hemorrhages or ischemia from that. And then, of course, non-arteritic anterior ischemic optic neuropathy is actually relatively common. So now we've got an adult in his 60s. He's a 6-year-old man with a history of hypertension and obesity. And he incidentally noticed vision loss in his non-dominant left eye when he was rubbing the dominant right eye. You see this quite often, and it becomes very difficult to work out when the vision loss actually occurred, because he's only worked it out because he accidentally occluded the dominant eye. So vision is 6/6 on the right, and count fingers with his glasses for the left eye. There is a left RAPD. And his blood pressure today in your rooms is 160 on 95. So this is him. So on the slit lamp with the lens, what he's got is diffuse intraretinal flame hemorrhages. that are covering the entire retina. So this is a central retinal vein occlusion. And they almost always have some macular edema. I don't know if that probably went too quick. I'll just see if I can go back. So this is an OCT, and it's just showing macular edema. As you can see, fluid beneath the retina, which is treatable. So retinal vein occlusions can be central retinal vein occlusions, like the one we just showed you, where there's an entire retina filled with flame hemorrhages. There can be hemivein occlusions, where just one of the basically half of the retina has a vein occlusion, like this picture here. So that's basically an inferior hemi vein occlusion. Or you can have a branch retinal vein occlusion, and that's usually at the crossing points where an artery will cross the vein and the artery will nip the vein due to elevated blood pressure, and then that vein will occlude. So it's usually related to high blood pressure or cardiovascular disease, and they often get superimposed macular edema, and they can also get secondary neovascularization. So they can get similar picture to the 25-year-old girl with the neovascularization of the disc. And these patients will often require intravitreal injections to control the macular edema, or even retinal laser if there is ischemia or neovascularization. All right, moving on. So now we have an adult in his 70s. So it's a 75-year-old man who's had progressive loss of vision in both eyes. He says he's having trouble with glare when he's trying to drive at night. Vision is 618 for the right eye and 624 for the left. So therefore, he shouldn't be driving. So as doctors, it is our responsibility to tell the patient, hey, you don't actually have enough vision to drive. So to drive, they need 612 or better in at least one eye. There's no RAPD. So what do we think is the most likely diagnosis? Yep, is cataract. So cataract is a clouding of the natural crystalline lens, and it results in decreased vision and eventually blindness if it goes untreated. So the cataracts develop slowly and painlessly. Worldwide, cataracts are the #1 cause of preventable blindness. And the symptoms include blurry vision, difficulty reading in dim light or poor contrast sensitivity, poor night vision, glare or halos around lights. And another one is actually frequent changes in the prescription of glasses. And that's because the lens gets fatter as the cataract grows. So as the lens gets fatter and fatter, but they get what's called a myopic shift. They become progressively more myopic as they go. So what are the risk factors for cataract? So diabetes, steroid use, oral or topical, or even steroid emollients in the skin, ultraviolet exposure. So people who work outdoors a lot don't wear sunglasses, smoking, ocular diseases such as retinitis pigmentosa or uveitis. Ocular trauma can cause cataract, and prior ocular surgery. So patients who have a vitrectomy, once the vitreous is removed, will always get a cataract because the vitreous is what supplies nutrients to the lens. The lens doesn't have a blood supply, so that's something to keep in mind as well. And also there's always genetic predispositions. So modern cataract surgery is awesome. Yeah, so it involves removing the cloudy lens with an ultrasound probe, and then we implant a new plastic intraocular lens that's rolled up like a taco through a micro incision, and it opens out into the eye. And surgery is really the only definitive treatment for cataracts. And cataract surgery is the most effective and most common procedure performed in all of medicine, with an overall success rate of over 97%. I'm going to show you some more things. So modern cataract surgery today has had, there's huge advances. And this is one of the things I love about being a cataract surgeon. Today, there are many, many different intraocular lens options that can actually leave patients independent of spectacles for both near and distance. Gone are the days where every patient has to necessarily wear reading glasses after cataract surgery. This here in the bottom corner, this yellowish looking lens is pretty new lens called a Vivity lens, and it's an extended depth of focus lens. So what it does is it actually gives patients good near and distance vision without any glare or halos that we used to see in the old-fashioned multifocal intraocular lenses. We can also correct astigmatism at the time of cataract surgery by putting astigmatism correcting lenses or toric lenses in. We have ways of working out where the correct axis is for that lens using the microscope that has an overlay technology. And we can also perform glaucoma surgery at the time of cataract surgery now, and the government will pay for this. So the government will not pay for the stents though. So your public patients will not get these. And eye stents basically dramatically increase the drainage of the eye and can be implanted at the time of cataract surgery. And they're fantastic for patients that have the dual diagnosis of cataract and glaucoma, as it can get them off drops. So the most common causes of blindness globally in people over 50 are cataract, glaucoma, uncorrected refractive error, age-related macular degeneration, and diabetic retinopathy. Now, I've chosen not to focus too much on glaucoma here because most glaucoma patients that we're gonna see in your practices and mine have open-angle glaucoma. And open-angle glaucoma is an insidious disease. They will not come to you and say, I can't see, because what they lose is their peripheral vision. Their central vision is maintained until the very end. So it's a disease that will very rarely present to a GP with sight loss. Now, acute angle closure is different. They will present with acute pain, red eye, very high pressure, corneal edema. But mostly, that is a patient who's presenting you with eye pain. So that's why I didn't focus too much on glaucoma here in this particular talk. So the final case is an adult in her 80s. She's 86 years old, and she presents with sudden visual loss in her right eye. So vision is count fingers in the right eye and still 6/6 in the left. So this is what her right eye looks like. So there is a large intraretinal and subretinal hemorrhage that is centered on the macula. And the fellow eye has a really obvious drusen that is again centered in that macular area. So what is the diagnosis? This is macular degeneration. What is the treatment? So the treatment is intravitreal injections. So patients with age-related macular degeneration are usually elderly Caucasians. What occurs is there's a lipofuscin deposits that build up beneath the retina in the RPE layer, and eventually these can become exudative, meaning abnormal blood vessels grow through Bruch's membrane and cause a big net of abnormal vessels, which we call choroidal neovascularization, and these cause macular edema, and in the worst case they cause hemorrhage. When you get a hemorrhage that big, it often causes a big macular scar and their vision's lost. So it's better to treat the macular degeneration before these types of things happen. There's also non-exudative macular degeneration, which you saw in her fellow left eye, which had good vision. And what you see there is drusen or geographic atrophy at times, which is when the retina gets thin without it being edematous or bleeding. And the treatment is intravitreal injections. What we are injecting is an anti-vascular endothelial growth factor. So these things were initially used actually for patients with gastrointestinal types of cancers to suppress the growth of the tumours. And then someone had the bright idea of injecting Avastin into someone's eye. And now we've developed better products that are similar, these anti-VEGF products, and they work so well. I've got heaps of injection patients who have maintained their vision for many, many, many years who otherwise would have gone blind from macular degeneration. So it's amazing. So we're coming to the end. So in summary, amblyopia is the most common cause of vision loss in childhood in Australia, and it is often related to refractive error or squint. Taking a good history of vision loss can help you determine the cause and therefore whether referral is urgent. The presence of an RAPD indicates a severe optic nerve or retinal problem. And as a GP, you have the power to help patients modify the risk factors for vision loss, such as hypertension, diabetes, sleep apnea, obesity, smoking, UV exposure, and I'm sure the list goes on. This is a list of my references. And this is again how to find me if you have any burning questions you don't get to ask now. So I'm a general ophthalmologist specialising in cataract and strabismus surgery. I basically see everything. I'm happy to take questions or urgent patients, including injection patients, glaucoma patients. I'm located in Glen Iris, Cheltenham Eye Centre and Eyes First in Springvale. You can find me on my website, which is lanadelporto.com. I'm also on Instagram as Dr. Lana Surgeon. Thank you very much.
Thanks so much, Lana. That was great. I didn't interrupt you, but there was a question. Maybe you can explain it better than I can. What's an OCT?
Yeah, okay. So good point. OCT stands for optical coherence tomography. It's similar to a laser. They use laser interferometry to create a three-dimensional image of all 10 layers of the retina. And you can do that not just for the macula, you can also do it for the optic nerve. And it's something I use a lot for my glaucoma patients because it shows you whether there's any actual loss of nerve fibers by showing you all of the layers of the retina at the optic nerve level. Hope that helps.
Yep, great. I don't know if there's any other questions. Can people quickly type them into the question box now? I don't have anything. No, a few thank yous. Yep. Okay, I might, if any more questions come up, I will ask you, but I'll just move on to my finishing remarks and reminders. So Jen, if you could just switch back to sharing my screen, please. Share my screen. And in fact, I do see a question come up. Can we access a copy of I'm assuming that's going to be slides? Yes. So Jen will be sending you all copies of the slides either in the next few days or early next week with a reminder to fill in the questionnaire survey for feedback. So yes, you will all get a copy. Okay. And I'm just going through my slides to remind me to tell you. Thank you, and thanks to Lana. Evaluation forms will be emailed by Jen at the end of this webinar, and she'll also follow up with some attendance certificates and copies of the slides. The video recording, I'll email when it's available, but it will probably usually is a couple of weeks, so don't expect it super fast. I'll also save the date for our next webinar, 27th of July. Mr. Christopher Brown's going to be speaking on nasal obstruction and sinusitis. Otherwise, thank you to our speaker, Dr. Lana Del Porto, for her fabulous presentation. Thanks also to Jen and Claire from the Northwest Melbourne PHN for your support, for bringing you this webinar, and really for their ongoing support of our GP education program. And thank you all for attending and contributing. We can stop sharing my slides. I'll just stop sharing my screen and just check there's no further questions. I don't have any questions. Lana, do you have any closing remarks?
No, just thank you for the opportunity and thank you for listening.
Oh, thank you so much. I mean, it was an absolute whirlwind. I loved that you did it in a case-based fashion, but it was a lot of information to digest.
I know.
But that's okay because we've recorded it.
Honestly, I could have talked for 10 hours. Yeah.
Totally, but we've recorded it so we can all go through it slowly in our own time and just make sure that information sticks. But that was really helpful, really practical. So I appreciate that. Thank you. So I think we can probably sign off. I'm just checking. Great webinar. Thank you. Awesome. Okay, so I'll sign off now and Jen will send everybody the link to the questionnaire, to the survey for your feedback. Thanks so much.
Thank you. Okay, bye.
Bye.